use the mind map on murmurs to brainstorm and remember everything that we know about them. So a murmur is an abnormal heart sound caused by turbulent blood flow within the heart or great vessels. And murmurs may be physiologic, which is innocent, or pathologic. The significance is that murmurs are important clinical findings that can indicate underlying structural or functional heart disease. And these characteristics help guide the diagnosis and management of several cardiac conditions. Or the classification of murmurs, they're generally classified by their timing, location, intensity, pitch, and radiation. So with the timing of the in the cardiac cycle, systolic murmurs occur during ventricular contraction, and the subtypes are ejection, systolic murmur, for example in aortic and pulmonary stenosis, often crescendo, decrescendo in shape, and another is pansystolic murmurs or holosystolic murmurs. For example, in mitral or tricuspid regurgitation, and also in ventricular septal defect. It begins with S1 and extends to S2. And the late systolic murmurs, an example is mitral valve prolapse, where murmur intensity increases towards S2. The diastolic murmurs occurs during ventricular relaxation or diastole, with the subtypes being early diastole murmurs, mid diastole murmurs, and late diastole or diastolic murmurs. With the early diastolic murmurs, an example is the pulmonary or aortic regurgitation. They are high-pitched and decrescendo. With the mid diastolic murmurs, an example is a mitral and tricuspid stenosis. It's often low-pitched with a rumbling quality. And for late diastolic murmurs, it's less common and may be associated with atrial contraction. Continuous murmurs extends throughout systole and diastole without interruption. For example, in patent ductus arteriosus. The other classification criteria can think of the intensity of breathing. Murmurs are graded on a scale from 1, that is barely audible, to 4 to 6, where it's loud with palpable throw, and with the pitch and quality. Pitch could be high, medium, low, with often correlates with the velocity of blood flow. And the quality describes as blowing, harsh, rumbling, musical, which can help distinguish between the different etiologies. The location and radiation. The location is best heard at specific auscultatory areas, like the left upper sternal bottom for aortic stenosis, and the murmurs may radiate to the neck, axilla, or back depending on the direction of airflow. The pathophysiologic mechanisms: remember turbulent flow, pressure gradients, and volume overload. So with the turbulent flow, normal blood flow is laminar. When the flow becomes turbulent due to stenosis, regurgitation, or abnormal communications, it produces vibrations audible as murmurs. With the pressure gradients, the significant differences in pressure across a valve or defects promote turbulent flow. For example, in aortic stenosis, high velocity flow through a narrow orifice creates turbulence and a crescendo decrescendo murmur. With the volume overload, regurgitant lesions, for example in mitral regurgitation, cause blood to flow back into the chamber, leading to hollow systolic murmur. For the auscultatory features and clinical examination, like I said, systolic murmurs, we have the aortic stenosis, mitral regurgitation, ventricular septal defects, and the rest. So in aortic stenosis, the timing realizes crescendo, the crescendo systolic murmur. The location is at the right sternal border, radiates to the carotids. The maneuver is louder with ejection fraction maneuvers like hand grip may reduce the murmur. Okay. So like I said, the murmurs may radiate to the neck, the axilla, back depending on the direction of the flow. The pathophysiologic mechanisms, you think of turbulent flow, pressure gradients, and volume overload. So with the turbulent flow, the normal blood flow is laminar, and when the flow becomes turbulent, it's due to stenosis, regurgitation of normal communications, and produces vibrations, audible as murmurs. With the pressure gradients, significant differences in the pressure across a valve or defects promote the turbulent flow. For example, in aortic stenosis, high velocity flow through a narrow orifice creates turbulence and a crescendo murmur. With volume overload, regurgitant lesion, for example, in mitral regurgitation, cause blood to flow back into a chamber, leading to hollow systolic murmur. With the auscultatory features and physical examination, systolic murmurs, the in aortic stenosis, the timing is crescendo decrescendo systolic murmur. It's located at the right upper sternal border, reduced to the carotids. It's louder with systolic ejection maneuvers like hand grip, which may reduce the murmur. The mitral regurgitation timing is hollow systolic murmur, located at the apex of the heart and reduced to the left axilla, with the qualities often blowing in character. The ventricular septal defects, the timing is hollow systolic murmur, location left lower sternal border, intensity may be harsh depending on defect size. With the diastolic murmurs, aortic regurgitation, the timing is early diastolic decrescendo murmur. The location, the left sternal border, quality high pace, and the maneuvers may be accentuated by rapid deceleration of blood flow. With mitral stenosis, the timing is mid diastolic murmur and is located at the apex with the patient in the left lateral decubitus position, and the quality low pitched rumbling sounds. They may have an opening snap. Continuous murmurs like ductus patent ductus alterosus, the time is continuous machinery murmur, and the location upper left sternal border, and the quality high pitched paced over with the diaphragm. So the dynamic auscultation and maneuvers, positional changes like standing, squatting, or lying down can alter the intensity and the timing of the murmurs by changing venous return and afterload. For the respiratory variations, there is right-sided murmurs, for example, tricuspid regurgitation may become louder during inspiration due to increased venous return to the heart, to the right heart. Pharmacologic maneuvers, administration of agents such as nitrites or beta blockers can modify murmur intensity by altering the cardiac hemodynamics. With the clinical implications and further evaluation, the diagnostic rule, murmur characteristics guide further evaluation with echocardiography, cardiac MRI, or other imaging modalities to assess structural abnormalities. With the management, the treatment strategies vary from medical management, that is afterload reduction in regurgitant lesions, to surgical interventions for a valve repair or replacement in severe stenosis. The prognostic significance, the intensity and progress of Murmurs can correlate with the severity of underlying heart disease and influence long-term outcomes. In summary, the murmurs are abnormal heart sounds resulting from turbulent blood flow and characterized based on the timing, whether systolic, diastolic, or continuous, and the intensity, pitch, and radiation. Auscultation using proper techniques and maneuvers is critical for distinguishing between the different types of murmurs. Pathophysiologic mechanisms include turbulent flow due to stenosis, regurgitation of normal communications, with the clinical implications involve further diagnostic evaluation and appropriate management to address the underlying cardiac pathology.